Good afternoon, everybody. My name's Kim Sutherland and I work at the Agency for Clinical Innovation in New South Wales and do a large piece of work in the Critical Intelligence Unit. And today I'm joining in with my colleague Louisa Walsh to talk to you about how we set up the Critical Intelligence Unit and its work in response to the COVID-19 pandemic. Before I start, I'd like to acknowledge the traditional owners of the land that we're talking to you from and also pay my respects to elders past, present and emerging. I'd also like to acknowledge the importance of consumers, patients, carers and really appreciate the contribution that they make to our work. So today we're going to talk about, as I say, the Critical Intelligence Unit and really focusing on three main aspects of its work. And we bring together three different types of evidence: research and literature, really drawing on what's been published in the peer-reviewed and academic literature; quantitative data, drawing on information and data sets both internal to New South Wales but also national and international data; and experiential evidence, that evidence that's drawn from consumers, from clinicians, from patients, that really inform so many of our decisions. So to talk a little bit about the Critical Intelligence Unit, this is the structure of the organisation. It was set up in March 2020, and it really involves a number of different subgroups. We have a clinical intelligence group, we have a research intelligence group and a stakeholder advisory group. And we have several work groups, a data analytics team, an evidence integration team and a data platform team. We report to ultimately to the Secretary, who's the head of the health system in New South Wales, and she has taken on the role of the incident controller for COVID-19. We also report into a clinical council that's set up for New South Wales Health and also a series of communities of practice, which are really focused around particular clinical areas such as ICU or respiratory care or primary care. So to talk a little bit around the kind of evidence that we pull together and the products that we release and develop. This firstly looking at evidence drawn from the peer-reviewed literature. So every day we release a daily evidence digest that collates all of the papers that are published each day and advice and guidance that are published by colleges and other international advisory organisations. That's distributed every morning, really just with and with hyperlinks so that people can keep up to date with what's been released each day. We also have targeted evidence checks that really try to answer particular questions, often on things like transmission, infection control, a whole range of subjects. We've done 100 evidence checks to date since March 2020. In the last 6 months, we've moved to a slightly different way of collating evidence and now produce what we call living evidence tables. And we currently have 7 of those. And that's a resource that's housed on our website, where each day, for many of the living tables, but for some of them, it's only once a week, we update it with emerging evidence. So we have one on vaccines, for example. So whenever there's a new study on vaccines, our table gets updated. And so this is a repository of the most up-to-date information that's available on vaccines, on variants, on long COVID or post-acute COVID syndrome, on transmission, on surgery and COVID. And so that's the go-to place where we have our repository, and that's a basis for which we build new products, and we often write an in-brief based on what's in that living evidence table. So the second type of evidence that we draw on is quantitative evidence. So we produce a number of dashboards. This is an example of a dashboard that we've produced every day since the 5th of March 2020, and that brings together data from public health, from system operations, so we can see how many people are currently in hospital, how many people are going to the emergency department. It also brings together critical inputs, so we can see how much stock we have, for example, of PPE and other essential inputs to the system. We can see around worker absences because of COVID-19, so where staff have to be furloughed. All of those pieces of information are brought together in the Incident Controller Daily Report. So we were going very steadily along until about June 2020. We had, as New South Wales, we had, I think, around 58 deaths up until that point. And then suddenly we had a Delta outbreak, and our situation has changed quite significantly in the last few months. We're now in the midst of an outbreak where we have 18,000, nearly 19,000 locally acquired active cases at the moment. And all of this is due to the Delta variant. We started quite slowly in terms of vaccine rollout, but we've had a real acceleration in the last couple of months. We're currently at around 4.5 million people in New South Wales have had their first dose, and 2.5 million have had their second dose within a population of 8.1 million. But this outbreak we've seen has really focused in 12 what we call local government areas, which are really characterised by diversity, often with low socioeconomic status and higher levels of disadvantage. So really focusing on that, trying to address this Delta outbreak has meant that we've had to go both broad and very, very granular. And when I say broad, we've set up a strategy which is whole of government. It's no longer just health. We've engaged across a whole number of government departments, from business, from police, right across different areas to try and tackle multicultural New South Wales, really trying to tackle this issue from multiple directions. So it's broad in terms of whole of government, but it's very, very granular in that we're really trying to understand what's going on at those local levels and why we may be having some public health issues in those areas, because we know there are things around disadvantage that can start to interfere with people's ability to engage with the public health advice. You know, they feel that they do have to go out to work because they have insecure finances, for example. So this is just a snapshot of another dashboard that we did that's really focusing on this Delta strategy, where we're really focusing on those LGAs of concern. But as I say, it's a much broader strategy. It's looking to intensify the vaccine rollout, which they've had an enormous success in the last couple of months, to broaden testing, to identify those risks, at an individual level in families and areas of disadvantage, to support people to comply with public health orders, to provide direct payments to individuals so that they can to help engage and be able to comply with the advice, to empower community groups to really galvanise people who are opinion leaders in local areas, to build partnerships with business and to support public services, and engage across emergency services, communication strategies which go across all of this, and to engage at that micro level. And what we found in this micro strategy is that really what's come to the fore is the importance of experiential evidence, understanding different people's perspectives, and putting that alongside the numbers that we often hear reported, but also the research that we often hear reported. And so with that, I'm going to hand over to Louisa, who's going to talk about some work that we did on indirect impacts, which really, really focus on that experiential evidence, which is absolutely coming to the fore now as we tackle Delta. Over to you, Louisa.
Thanks, Kim. So just a quick introduction. My name's Louisa Walsh. I have a background in physiotherapy and strategic communications, and at the moment I'm finishing a PhD related to consumer engagement in public hospital design and improvement. And I'm also a person with a lived experience of chronic disease, a lifelong chronic disease that was diagnosed when I was a baby and has meant a lot of contact with hospitals and health services throughout my life. and I've been involved in consumer representative roles as well. So as Kim mentioned, I'm going to speak about the experiential evidence that informs the work of the CIU and how that ties into some of the key principles which overarch the CIU's approach. So last year, I was part of conducting research into people's experience of the indirect impacts of COVID-19 on health and healthcare. So indirect impacts are those which aren't caused as a result of an individual being infected with COVID, but are rather those secondary or flow-on impacts that are caused by things like a lack of access to services, restrictions on movement, and social isolation. Obviously, this research is highly relevant now. As Kim explained, the current COVID outbreak that is being experienced in New South Wales has significant impacts on people's access to healthcare and other services. So experiential evidence is one of the data types that informs the CIU's recommendations and approaches. Experiential data really tells us about people's real-world experiences in a way that quantitative data, such as case numbers, rates of hospitalisation and vaccination, just really doesn't. So experiential data allows us to see what matters to people and what they're thinking, feeling or doing in response to COVID-19 and the public health orders. That experiential data also can help with tailoring solutions and approaches to specific community needs. All right, so on to the project. So we aim to explore the impacts of missed or delayed healthcare on consumers and community members. Please keep in mind that we undertook this consultation 12 months ago, and that was a time when the New South Wales case numbers were averaging under 10 new cases a day and mostly were in hotel quarantine. So it's obviously a very different picture to the one that Kim presented earlier. However, we believe that these experiences are still highly relevant now that the movement of people and access to healthcare is even more restricted than they were last year when we did this research. So as part of this research, we held 3 consultation sessions over a very short period, just 3 weeks. The first session was a briefing, which outlined the international research and the local New South Wales quantitative data related to the indirect impacts, such as the rates of elective surgeries and waiting lists. And you can already see that we're weaving in those 2 different data types, the research literature that exists already, and also that quantitative data that the CIU collects. At the second session, we asked participants to share the impacts that they had experienced, had heard about through others, or had concerns about. After that session, we analysed the data into some draft themes, priorities, and recommendations around different impacts. So on to talking about the project. We aim to explore the impacts of missed or delayed healthcare on consumers and community members. We undertook the consultation 12 months ago, and that was a time where the New South Wales case numbers were averaging under 10 new cases a day, mostly in hotel quarantine. So obviously a very different kind of picture to the one that Kim presented earlier. However, we believe that these experiences are still highly relevant now that the movement of people, access to healthcare and social isolation is sort of even more stark than it was at this time last year. So we held 3 consultation sessions over a very short period, and that was just 3 weeks. The first session was a briefing which outlined the international research and the local New South Wales quantitative data related to the indirect impacts, so things such as rates of elective surgeries and waiting lists. And you can already see that we're starting to weave in those other data types that we talked about earlier in the presentation, so things like making use of existing international research and also bringing in the local quantitative data that the CIU collects. At the second session, we asked participants to share the impacts they had experienced, had heard about through others, or had concerns about. After that session, we analysed the data into some draft themes, priorities and recommendations around the different impacts that the participants talked about. This document was then reviewed in the third session, and we created a final draft from the feedback we received from the participants. And then this final draft went back to them for any further comments. So after the last round of feedback, we finalised the report to be used by the Health Department and policymakers, and we also wrote the academic paper, and that was what we had highlighted on that previous slide. In terms of results, we found 3 main themes of the indirect impacts that our participants talked about. The first theme discussed poor health outcomes for individuals because of those restrictions on movement, the impacts of social isolation, or that difficulty accessing healthcare. And those were things such as poorer mental health, decreased access to outpatient and community health services, and the potential for increased family violence. The second theme looked at the impacts on healthcare itself, and that was things like decreased consumer input into service design because a lot of the consumer engagement activities were halted. Participants talked about the benefits and risks of telehealth, and there was also issues brought up around state border closures causing problems with access to services in cross-border communities. The third theme examined increasing health inequity caused by the pandemic, and we might be seeing some of those things that our participants predicted last year sort of coming to the fore now. So things like higher impacts on more vulnerable communities and issues with public health communication and information not being sufficiently targeted to some of these vulnerable groups. So the Indirect Impacts project really demonstrates some of the principles which overarch the way the CIU operates. So we've talked through the presentation about this way that the CIU uses different data sources, so that international research literature, the quantitative data that they collect locally, and also this experiential data to build a complete picture of what's happening and plan solutions or approaches that might be appropriate. Consumer experience was very valued in the Indirect Impacts project. And this was demonstrated through the commitment of involving a consumer co-facilitator, which was me. And that was from recruitment through to writing the academic paper that I was involved. But also we involved our consumer and community participants not only in sharing their experiences, but they also helped shape the prioritisation of impacts and the recommendations that were then passed on to government. People in the CIU are definitely versatilists. So they come from a range of different backgrounds and are encouraged to bring their diverse experiences, networks and partnerships into their roles. And this was apparent for me not only through working with CIU staff on this project, but also through the range of people who participated in the consultation. So that included individuals who were connected to different community groups, representatives of consumer and health and community service organisations, and people with lived experience of being patients and carers. So this very cross-disciplinary and highly networked way of working also means that the CIU are able to conduct research which others can't, just because of their range of skills, experience and extensive networks. And finally, as for RAPID, I think that this project was a month or 5 weeks from start to finish with a little bit of extra time to write that academic paper. So for me, coming from a university environment, it was very refreshing to work somewhere with an approach that wanted to produce data quickly and get the results in the hands of policymakers who could use it to make real differences to people's lives. And the CIU definitely doesn't let the perfect be the enemy of the good when it comes to producing data. So Kim, do you want to talk about some of the future work that is coming up in the CIU?
I do. Thanks very much, Louisa. Just a final slide now, just to say where next, where are we headed? Well, the Delta outbreak, of course, is still occupying us and very much in terms of that rapid and good enough evidence. So sometimes for some of the reports, we're on a 24-hour turnaround time. So very much that idea of responsive and trying to inform decision making. We are doing quite a lot of work just coming that's coming to the fore on what we're calling a science table, which is modelled on an idea that was established in Ontario, where lots of different statistical models are put together and really examined critically to understand how they, all of their assumptions, the parameters that they're based on, the predictions that they're making, because we do find that there is quite a lot of models published and they differ quite a lot in their predictions. And so we want to get a little bit more clarity around that. We're increasingly trying to support operational decisions. We're not an operational group. We are supporting those operational groups with, critical advice and integrated evidence. We're learning from other jurisdictions, really bringing together experts both nationally and internationally on particular topics, and really seeking to be developing analytic development, really bringing together in an integrated way all of this evidence that we've been talking about. We still continue to track and try and highlight when evidence is emerging, where there are new areas, where there's new concerns, new variants, dare I say it, new information, particularly around vaccines and long COVID. And we're also tracking changing sentiment, and we can see that, particularly in experiential evidence, of how people's opinions and the values and their behaviours are changing as the pandemic is progressing. So with that, I'll say thank you very much for listening to us. It's been a real privilege to be able to tell you about our work at the Critical Intelligence Unit. Thank you.